Hello, I'm Rustam Al-Shahi Salman in Edinburgh, and it's my pleasure to introduce Dr. Johnston, who's the principal investigator of the Thales trial. Many of you will already be well aware of the results that were published in the New England Journal back in July 2020, a phenomenal achievement to compare ticagrelor and aspirin to aspirin alone in more than 11,000 patients with non-cardioembolic ischemic stroke, or TIA. The result of that trial that you will know showed a significant reduction in the risk of the primary outcome event, which was stroke or death within 30 days for ticagrelor and aspirin combined. On the other hand, although the incidence of disability didn't differ significantly between the two groups, severe bleeding was more common in the ticagrelor aspirin group. So the Thales trial left us with some uncertainties, and that's what you're addressing in this presentation at Esoc. Could you tell us about it, Dr. Johnston?
Sure, yeah. So your summary was good. We did see a reduction in disabling stroke, but we did not see a reduction overall in disability, which would obviously include the disability from the index event that got people into the trials as well. So there's a lot of noise in that. We probably never should have tried to look for disability as an outcome in the trial. But the trial results itself have been a little hard for folks to interpret, and we've seen lots of different interpretations. The outcome measure actually included stroke and death, so it included hemorrhagic stroke and death from hemorrhage. And then the safety outcome includes also hemorrhagic stroke and death from hemorrhage. And so there's sort of a double counting of those events on both sides. And the other thing that was done typically, but also created some confusion, was an emphasis on relative risks. So, there's a real reduction in ischemic stroke and a real increase in hemorrhage. If you just look at the relative risks, you don't understand how to balance those two. So in this analysis, and we've seen that, it's playing out even in guidelines, people carefully reading the documents are still getting things wrong in terms of thinking about how to integrate these data. And so we thought, okay, well, let's just disentangle the outcomes, and then let's look at disability of the hemorrhage, of the ischemia, and present that and show it by absolute differences. And this was also, I should say, this was not a predefined analysis in Thales, but it was requested by the regulatory authorities. And so it was guided by their recommendations for that analysis.
This secondary analysis is really valuable because it's addressing a common problem for those of us interested, not just in protecting patients against one specific event, but looking at net benefit in the round. So I think these are really helpful analyses. So could you tell us about your overall findings in the study now?
You bet. So the overall, so if we looked at the primary efficacy and safety outcomes from the original trial, there's about a 1% reduction in the composite of stroke and death and a 0.4% increase in gustose severe bleeding, which was our primary safety outcome. Those are entangled, of course. So then when we disentangle them, they change a bit, not a ton, but a bit. It's 1.2% absolute benefit in major ischemic events and 0.3% increase, so about a 4-to-1 ratio of benefit to risk. And then if we looked at that using a couple of different disability thresholds, because one of the concerns was, well, yeah, fine, but hemorrhage is far worse than an ischemic event, so you should count those 4 times, and then there is no, well, that's not the case. So if we define disability as an MRS score of greater than 1, so 2 or greater, then that ratio stays the same. It's now a reduction of about 0.8% and with a risk of about 0.2%. And then if we define it as a 3 or greater, so pretty moderate to severe disability, then it's still that same ratio, 0.7 versus 0.18. So it's not that different from the original results, but it clarifies, yes, there is a risk, there is a price, but the benefit exceeds that price, even when you consider disability in the equation.
Just out of interest, do we have much data from patients themselves to understand what trade-offs they're prepared to accept here, what severities of outcome events they're prepared to trade, perhaps based on utility values if such data have been collected?
We did not collect that data. There, as you know, there are studies that have looked at mapping utilities to specific MRS scores, and that would still suggest a preference for treatment. Not surprising given that ratio of 4-to-1. So if we actually aren't publishing this analysis, but if you look at, we will eventually publish this. If you look at that, that estimate of utility based on prior declared preferences, yes, ticagrelor is preferred.
And then you went on in this paper to look at effects on net clinical benefit in subgroups. Can you tell us about those?
Sure, yeah. So then we combine those two now non-overlapping outcomes to create a net clinical benefit outcome. And we also looked at the two separately amongst the previously defined subgroups from the study. And bottom line, there were no interactions. There was no subgroup in which the ticagrelor was clearly superior, more superior than it normally is, and a subgroup in which you could say, no, don't treat that subgroup. There were some trends, and I just, there's always trends, right? When you look at enough subgroups, you're going to find trends. So that shouldn't be surprising. And, one was age, that there was a little greater risk of hemorrhage as you get older without a commensurate increase in benefit, but it didn't overwhelm the benefit. So that would be one. The over 75 group benefited. And then the net benefit was a little less in that group. Again, interaction was not significant. The other where the interaction term was almost significant was in those with prior ischemic stroke or TIA. They had a disproportionately greater net clinical benefit, but not so much that one shouldn't treat those without a prior ischemic stroke or TIA. So again, doesn't really dictate a change in treatment.
So these are very reassuring findings, I think, for patients, for clinicians, and probably also for regulators. So perhaps we could just wrap up now by you telling us what you think the clinical implications of your findings are, and in particular, whether you've got any words of wisdom for secondary prevention trialists in the stroke world about how to go about choosing composite outcomes in the future. Yeah.
So first of all, I think we're still under-treating patients with dual antiplatelet therapy after a moderate now ischemic stroke and high-risk TIA. I think that we need more data to show just how much we're under-treating. I think we'll discover it's substantial, and we need to address that as a quality issue now, not just based on this trial, but based on point and chance. And we have plenty of data that shows either Tradeoffs or Ticagrelor-Aspirin should be used in the patients that were enrolled in these trials. So hopefully we'll start to do that more, and we'll gather more data on which of those two agents to choose. I don't think an indirect comparison is the right way to make that determination at this stage. And then for future trials, I do think we should push towards using non-overlapping safety and efficacy outcomes. We always move to them, right? Even if we try to come up with some composite outcome or one that captures most of the risks and benefits, there's always a question about the safety too. So we're always stuck reporting that as well. So rather than entangle the two, just separate them out. I think that just makes sense. It's the way we consume the data. So why not prepare for that ultimate consumption? And the second is, this is an old thing, right? To use absolute rather than relative risk reductions when we report the primary results of the trial. I think we just need to get accustomed to doing that. Maybe we show both, but let's make it clear, that there's a relative really doesn't tell us much when we're thinking about trade-offs.
Yes, well, some journals compel us to do that more than others. And thank you very much for telling the full story. I'm sure there's more to come from the Thales trial. But on this occasion, Dr. Johnston, thanks a lot for summarising the results for us and for some words of wisdom, which will hopefully herald a new era of a proper examination of net clinical benefit in secondary prevention trials. Thank you.
Thank you.